Bismillahirrahmanirrahim. The fibrosis and scarring are the two terms that are used interchangeably, but there are some differences among various mechanism and other aspects of these two terms. In this video, these are highlighted. Following are the references for this video. In the process of the wound healing, there is localized transient scarring, and that will lead to resolution of local injury. There is altered deposition of the matrix compared to the normal surrounding tissue. The tissue that is replaced or the scar tissue may be larger than the wound site, and there is typical response to tissue ischemia or infarction where resident cells cannot be replaced. While in chronic diseases of the skin or parenchymal organ, when there is persistent of inflammation, there is diffuse and progressive fibrosis that is due to continued and excessive deposition of the matrix protein and collagen. There is differentiation and activation of the fibroblast. Both inflammatory and non-inflammatory factor cause cardiac, hepatic, lung, and kidney fibrosis. In kidney, the glomerulosclerosis may result from infection, hypertension, or diabetes. In lung, there is the persistence and inflammation due to repeated inhalation of the smoke or inhaled silica particles that induce chronic inflammation in the lung, while other disturbances of the alveolar epithelial type 2 homeostasis foreshadow development of life-threatening idiopathic pulmonary fibrosis. So some diseases such as rheumatoid arthritis that affects joint lead to differentiation and activation of the fibroblast, in which there is persistence of inflammation and diffuse and progressive fibrosis occurs. This table is summarizing the salient feature of fibrosis versus scarring. The trigger for scarring is acute and localized injury or ischemia, while the trigger for fibrosis is persistent or chronic inflammation. Often it is immune mediated. The nature of scarring, nature of the injury is localized and it is controlled matrix deposition, while in fibrosis the injury is diffuse, excessive, and progressive extracellular matrix deposition occurs. In scarring, the outcome is that it stabilizes tissue with limited functional loss, while in fibrosis there is ongoing dysfunction, organ stiffening, and potential failure of this organ. The cellular role in scarring involves fibroblasts transitioning into myofibroblast, while in fibrosis there is sustained fibroblast activation, often with immune system involvement. The reversibility of the scarring, it typically stabilizes and mature, while the fibrosis is irreversible without intervention. The examples for scarring are surgical wound and myocardial infarct scar, while the fibrosis examples are scleroderma, idiopathic pulmonary fibrosis, glomerulosclerosis that occur in diabetes, and rheumatoid arthritis. The tissue environment in scarring, it resolved inflammation and mechanical stress area is present in the scarring phenomenon. While in fibrosis, the chronic immune stimulation, toxic exposure, and metabolic disease is present. The matrix composition in the scarring is predominantly type 1 collagen is present in organized pattern, while in fibrosis, abnormal extracellular matrix, often with altered collagen cross-linking, is present. This visual analogy beautifully simplifies the clinical difference between adaptive and pathologic connective tissue response. It uses houses as analogies to contrast fibrosis and scarring in tissue repair. In fibrosis, the house is damaged, and this represents tissue with structural damage and dysfunction. The cracks and smoke indicate ongoing or chronic injury and impaired function. Thick bundles of collagen signify abundant excessive collagen deposition typical of fibrosis. The underlying tissue it appears overwhelmed by the collagen, symbolizing distorted architecture and impaired function. While in scarring, the house is stable and intact. It represents localized and functional tissue repair. Limited cracks or no smoke suggest that damage has been resolved. Smaller collagen bundles over here in scarring, they indicate controlled collagen deposition, typical of a normal scar. The underlying tissue maintains more of its original structure. So, in fibrosis, this indicates chronic tissue injury, excessive collagen, and loss of function, while in scarring, it is controlled healing, minimal collagen, and function is retained. So, how this chronic inflammatory or fibrogenic response is activated? When tissue is repeatedly injured or inflamed, it becomes chronically inflamed. M1 macrophages and Th2 and Th17 lymphocytes dominate the scene. They secrete pro-inflammatory cytokines like interleukin 1b, interleukin 6, and TNF alpha. Also, they release fibrogenic growth factors, especially transforming growth factor beta, which drive fibroblast activation and collagen deposition. The process is worsened by the activity of matrix metalloproteinases that degrade extracellular matrix but paradoxically lead to disorganized tissue and scarring due to an imbalance between their inhibitor. When inflammation subsides, M2 macrophages they come into action. They are involved in repair, debris clearance, and anti-inflammatory signaling. Th1 and T regulatory cells can also contribute to halt the fibrosis and to promote normal tissue architecture. So you can think of M1, Th2 and Th17 as overactive repair crews that keep pouring cement on a road under construction, eventually turning it into a thin, immobile slab. That is fibrosis. On the other hand, M2, Th1, and T regulatory, they act like cleanup and quality control teams, making sure the road gets finished properly and the surrounding area is restored, not buried. This diagram is summarizing the damage in the parenchyma that results in fibrosis. The fibrosis refers to excessive deposition of collagen and extracellular matrix component in tissue, often used interchangeably with scarring, but fibrosis it generally describes internal organ involvement in chronic diseases. It is triggered whenever there is injury to the epithelium or parenchyma. It it results in loss of integrity. If it is limited, the epithelium may be regenerated. But if it is repeated or severe injury, there is onset of inflammation and involvement, and this inflammation is chronic infection or maybe some immunological reaction. There is involvement of uh, transforming growth factor beta, matrix metalloproteinase, and also cytokines that come from T lymphocytes and other lymphoid cells. So they drive the fibrosis. Cell death occur via necrosis or apoptosis, and reactive oxygen species activate the transforming growth factor beta. The myofibroblast, they are differentiated from the fibroblasts that are recruited to this area in the extracellular matrix, and these myofibroblasts are responsible for the various changes that we have already seen in previous videos. The hepatic stellate cells are the primary collagen producers in liver cirrhosis. What are the pathological consequences of this mechanism? This mechanism leads to remodeling of the tissue, organ dysfunction, and ultimately there will be organ failure if it is unchecked. The common fibrotic disease in the liver is cirrhosis. In the lung, it is idiopathic pulmonary fibrosis, pneumoconiosis, and radiation-induced fibrosis. In kidney, this fibrosis may lead to end-stage renal disease, while in heart there is constrictive pericarditis. This fibrosis can be systemic also, in which the systemic sclerosis is one of the example. So there is growing focus on anti-fibrogenic therapies to preserve the function of these organs and to slow the progression of the disease. So fibrotic reaction, if it is a smaller one, it may resolve, but if it is continuous and persistent, it may alter metric composition, stiffness, and mechanical stress. And fibroblasts, they transform into myofibroblasts. That will lead to further production of the matrix, and there is change in the composition of the matrix, and there is support for more fibrogenesis and remodeling by the action of myofibroblast, and there is continued fibrosis. These myofibroblast activities self-perpetuate, and they may result in uncontrolled fibrosis in the absence of inflammation. So there is architectural disruption, and that will lead to functional impairment in major organs such as heart, lung, kidney, and liver. There is loss of muscle, loss of alveolus in the lung, kidney glomerulus or tubule, they are damaged and destroyed, and liver lobule may be destroyed, as happens in the cirrhosis, and all these are replaced with the uh, collagen that is disorderly arranged, and this phenomenon is irreversible. So here in this picture, the fibrosis in the parenchymal organ is compared with the normal parenchyma. It contrasts the structure and cellular makeup of normal parenchymal tissue over here and with the fibrotic tissue. So in the normal parenchyma, the cell organized The cells are organized like these epithelial cells, forming functional tissue, working tissue, and the stroma is composed of lightly stained connective tissue supporting parenchymal cell. The side lacks dense collagen, highlighting healthy tissue structure. Whereas in fibrosis, the collagen network is dense, that is wavy pink to red bundles indicating excess extracellular matrix deposition. The myofibroblasts are present, that is embedded among the collagen fiber. It is responsible for collagen production and tissue contraction. Transforming growth factor beta, it is a major fibrogenic cytokine, shows an arrow pointing to the fibrotic zone, emphasizing its role in the driving myofibroblast activation and fibrosis. So this image is communicating how fibrosis replaces the functional tissue with dense collagen, impairing organ function. It especially uh, relevant to chronic diseases like liver cirrhosis, idiopathic pulmonary fibrosis, and kidney fibrosis or end-stage kidney disease. So the key molecules that are involved in fibrosis, the spark or secreted protein, acidic and rich in cysteine, BM14 or osteonectin. They are this is a matricellular non-structural extracellular matrix protein, and it is secreted during development and fibrotic process, dissociates collagen from cell surface by competing with discoid domain receptor, encourages further collagen composition, and it worsens fibrosis. Osteopentin is also a matricellular protein, and it is found in persistent fibrosis across several organs. It is implicated in chronic scarring and tissue remodeling, gone awry. The organ level impact of these cytokines is in fibrosis. In hearts, these disrupt myocardial elasticity. In lung, they impair alveolar gas exchange. In liver, they replace lobules and lead to cirrhosis. And in the kidney, they destroy glomeruli and tubule, causing renal failure. These changes replace functional units with collagen, which alters the architecture of the tissue, reduces mechanical efficiency, and compromise function of the organ. So this fibrosis is irreversible, especially once collagen is mature and cross-linked. Restoring function typically requires the removing of the underlying cause, such as treating rheumatoid arthritis or infection, and suppressing inflammation early to minimize extracellular matrix damage. So this fibrosis is not merely scarring. It is a pathological transformation of tissue in response to chronic or unresolved injury. Though it helps maintain structural integrity, it often sacrifices function in the process. Prevention of fibrosis is achieved either by blocking the stimulus of matrix production or by increasing the level of matrix degradation. So, transforming growth factor beta and connective tissue growth factor or CCN2, they are primary stimulator of collagen and matrix protein production. Overactive transforming growth factor beta and connective tissue growth factor may be associated in fibrotic disease. The therapeutic inhibition of these growth factors can reduce scar tissue formation. Then there is Wnt beta signaling pathway that promotes the fibroblast activation. The microRNA they regulate fibrotic gene expression such as silencing antifibrotic gene. So then there is enhanced matrix degradation that is achieved by inhibition of the plasminogen activator inhibitor that activates the plasminogen and it is converted into plasmin, and it is direct by uh, it is by direct action of the plasmin or through matrix metalloproteinases that enhance further extracellular matrix clearance. The outcome is the reduced glomerular scarring and preserved function of the kidney. So this phenomenon has got some surgical relevance. Whenever there is intra-abdominal, whenever there is surgery, there may be formation of intra-abdominal adhesions. They can be initiated by fibrin clots after mesothelial injury. If fibrin isn't cleared in time, the fibroblast invade and become fibrous adhesion with blood vessel and nerve. So plasminogen activator inhibition may prevent this by accelerating the fibrin clearance. Think of the fibrosis like an overzealous repair crew that lays down too much concrete, that is the collagen, after a building crack. The key is to limit unnecessary construction, the transforming growth factor beta and connective tissue growth factor, and bring in more cleanup crew that are plasmin and matrix metalloproteinases before it become a hazard. So the resolution of the fibrosis involve more than simply dialing down fibrogenic stimuli or waiting for tissue strength or flexibility to normalize. Emerging research point to a critical role played by CXCL chemokines, particularly CXCL10, that is also termed as IP10 or interferon gamma inducible protein 10, and CXCL11, that is IP9, in actively counter regulating fibrotic pathway. So these chemokines are produced by fibroblast, epithelial cell, and immune cell in response to inflammatory and immune signals, notably the gamma interferon. And these CXCL10 and CXCL11, they signal through the CXCR3 receptor, which is involved in modulation of immune response and suppressing fibroblast proliferation. They help in reducing extracellular matrix accumulation, essentially tipping the balance away from fibrosis. Increased expression of CXCL10 or IP10 and CXCL11 IP9 has been associated with fibrosis regression in experimental model. Knockout or deficiency in these chemokines can lead to exaggerated or persistent scarring, underscoring their antifibrotic importance. The fibrosis resolution is not merely a passive process. CXCL10 and CXCL11, they act like molecular brakes on scarring by by interfering with the fibroblast activity and extracellular matrix deposition. Their presence actively promotes the tissue remodeling and healing without fibrosis. So in this picture, you can see that there is presence of adhesion. This adhesion is between the right lung and chest wall. It is a fibrous tissue connecting two surfaces. This fibrous transparent tissue is connecting these two surfaces that are normally separate. So the fibrous band is a translucent membrane structure. It stretches between the two organs or tissue. This can be present in the abdomen also after abdominal surgery, infection, or may be present after inflammation. So in here it causes the restriction in the normal function of the lung, and whenever present in the abdomen, it may result in intestinal obstruction, chronic abdominal pain, and complication during future surgeries. And it is formed due to improper resolution of the fibrin clot during healing. If fibrinolysis fail, fibroblasts invade and produce collagen, converting the temporary matrix into permanent fibrotic adhesions. Thank you for watching this video. If you have any question, please write in the comment box.